like she's never left because we've kind of continued to work with her over the years since she's left Miller. So she was actually an intern here, was it 2013, 2014-ish? Yeah, and we have a couple other alumni here as well, hanging out for moral support. So Miya was actually, when we were thinking about kind of, trying to serve more at-risk communities, Miya was really at the forefront of us being able to do that specifically within Little Havana. It really helped with the development of like our natural helper program that we use within PCIT. She since has gone on to do an amazing postdoc at UCLA. We know how one of our interns is going off to do a postdoc there next year. And then she, a couple years ago, got a faculty appointment at UC Santa Barbara, where she now has a K Award. So she is doing awesome. She was doing awesome before she got here, but she's doing even way better after she left here. So we're super excited to have her back. She has over 20 pubs. And what I really like about why I thought that, what, should I?
No, I'm impressed. She got another one yesterday. Did she tell you that?
Another pub yesterday? Okay. Congratulations. You integrated that into your presentation for today, right? Yes. Okay. But what I've always loved about Miya's work is like recognizing that, while she'll focus on mental health services because it is the promoting behavioral health IBC plan, is one of the things that she's really tried to push going forward is how do we meet the needs of the people that really aren't getting these services or in community settings. So I'm really excited to have her kind of chat with that about us. Even though she's here for one day, we get to work with her on our TCIT project and she still provides some consultation related to our PCIT and natural helper, but we're glad to share her with the rest of you. So please join me in welcoming Dr. Barnett.
Thank you so much for having me, and that was such a heartwarming introduction, and I couldn't be more happy to be back at Mailman. I just always consider this my home, even though it's been so long. So today I'm really excited to talk about the role of implementation science on disparity reduction and how we can really work on increasing access and acceptability of evidence-based practices in children's mental health. So this is going to go over some of the work that I did here in Mailman and started and really where I've been since then. To start with, I just want to go over an outline of the talk. I want to give an overview of exactly what implementation science is and what I mean by that, and then have us all really think about how implementation science and the implementation of evidence-based practices, what this could potentially do to impact mental health disparities for our at-risk, underserved communities. And then I will have 2 examples of implementation research that is focusing on making evidence-based practices more acceptable and accessible in community settings. So to get started, for those of you who have been involved in research studies or continue to conduct research studies, what we know is that there's this huge gap between what happens in research and what happens in practice. So even maybe if you're thinking about different rotations that you've done or places that you've practiced, what's happening there might look very different than what's coming out from research studies, right? And this has been described as an odyssey, a 17-year odyssey, where from the point that, the NIH or maybe SAMHSA puts out priorities for research funding, and then the grants are reviewed, and then eventually you do the study, then it gets published, then it gets synthesized, you really start to say, okay, there's a few studies here, then you start to have guidelines, this is what we should be doing in practice, in our medical practices, in our mental health practices, in assessment, early education, any of that. That can take 17 years to happen. And the practice, what actually happens is just a tiny drop in the bucket. Actually, only 14% of research even makes it to benefit patient care. So we're losing an enormous amount from the research that we're doing. It's not really changing public health in the way that we might expect it. So that's why we're starting to think about why do we need to study implementation of these things. The other thing that happens with implementation is called the implementation cliff, or sometimes it's called the voltage drop. And this is the idea that you might have a very strong effect of research in a research study. You know, this evidence-based practice has a large effect size, and then you do it in a community sample, you look at it a few years later, and it's not such a large effect size anymore, maybe none. What's going on there? So I like this one key example to really think about this. This is going to require some audience participation. So this is an evidence-based practice. It's the most effective intervention to prevent the 10th leading cause of hospital deaths worldwide. So it's a little bit of a riddle. And less than 50% of physicians implement it correctly. What? You guys know it. This is hand washing. Hand washing is an extremely effective intervention. It is an evidence-based practice. But it's not implemented correctly. And we're losing the effects in practice. People look horrified. That's fair. That's fair. Now let's think about this for a minute. Hand washing, and I realize we're not just talking about, I mean, honestly, all of us are probably implementing hand washing incorrectly, even going before we, you know, make dinner or something. We're not going long enough and all that. But it's relatively basic. It's relatively easy to implement. You think about mental health interventions and what they require you to learn and to be able to implement correctly. And all of a sudden it becomes very clear that there might be a reason why we're having this voltage drop or this implementation cliff, right? And so implementation science is really part of the research pipeline to understand how you get things from bench to bedside. So translational research is something we're talking about a lot right now, and often it's talking about sort of what's happening right here in these arrows. How do you translate pre-intervention research like lab-based rat models into a research study, like could this treatment work? Is there a principle behind it? Then you do an efficacy trial, right? These are your well-controlled university trials. You have master clinicians doing it, small caseloads, very controlled. That tells us, does a treatment work? The next thing that people often think is the research that I do is effectiveness studies. Effectiveness studies is you leave the ivory tower and you go into more community-based settings and you see, does this treatment continue to work in more real-world settings? But the research that I'm talking about today, implementation science, is the next step. It's how you make that treatment work. It's the study of what needs to happen there. So you can even break it apart for implementations. What leads people to explore if they're going to do this evidence-based practice? What facilitates adopting this practice? What happens in implementation? How is it implemented? What's the fidelity to the model? And also sustainment. Does it stick around? You bring a training to a community. Does that knowledge stick around? Does practice change? So those are the types of questions I'm really interested in right now. And implementation outcomes are not like our effectiveness outcomes. We're not looking, does the patient's behaviors necessarily or symptoms get better? It's what's going on with providers often at the agency level, at the individual therapist level. So you look at things like acceptability. What are the attitudes towards this practice? That could really impact if somebody's willing to adopt it even. How much does it cost? And not even just cost benefit, but just how much does it cost to bring this into the community? A lot of our agencies that work in communities are on very tight budgets. And so they care a lot about implementation costs. How much is the training? How much time is lost to having to engage in training and consultation that they're not able to bill and do productivity? Again, is it adopted at all? Penetration is really this idea of how many eligible patients actually get the care. So if you're thinking about PCIT, if there's 100 kids who are served by an agency that are between the ages of 2 and 7, and they have difficult behaviors, Out of those 100, do 10 of them get PCIT? Do 100 of them get PCIT? How many are we actually reaching out of eligibility? Fidelity, you know, to the model, and then sustainment. Does it stick around? How long does it stick around? So a little bit of a different way to look at these outcomes opposed to what we're usually more used to, which is it working? So just stepping back, moving on to mental health. The good news is we now have a lot of interventions that have been shown to be effective. And most of these actually really do not only have efficacy data on them, but they have effectiveness data. We've seen a lot of these interventions work in real world settings. And because I know that this audience is very familiar with PCIT, and obviously that's a model that I'm familiar with, I'm going to show examples of PCIT, parent-child interaction therapy. So, you know, we have this great news that this is just one finding from parent-child interaction therapy, that if you look at parent ratings of child behaviors pre-treatment, they're above 130 range. So that means that they are clinically significant. But then after treatment, they're way below that. And those effects are lasting for a couple of years. So we have these really good treatments that can change kids' behaviors for a long time. This is huge. This is important. Children's behavior problems have a huge cost to society and school and personally. So it's great. We have effective treatments like PCIT. There's bad news. There's some bad news. We thought, I would say, you know, 20 years ago, 40 years ago, these treatments were first being developed. 20 years ago, people started thinking we should start spreading these a little bit more. I think people were like, yeah, this is it. We're gonna like change public health forever with these interventions. Kids are not gonna have behavior problems anymore. And the bad news is that we have a little bit of a limited impact. The potential of interventions like PCIT is not being met because there are some real challenges implementing it in community settings, right? And there's poor client engagement when we get there, and it's limiting the public health impact that we're actually having with these interventions. And so we know for, again, looking at PCIT as a case example of an evidence-based practice, all of them have these issues. I'm not picking on it. We know that the good news, again, with PCIT, if you complete treatment, 2 to 6 years later, this is follow-up, you have these nice drops, and they stay around at follow-up. If you drop out of treatment, at follow-up, it's not looking as good. You personally are not having those good effects from the treatment. So dropping out is something that we're concerned about. And then in community settings, dropout in PCIT is about 60%. And this has been found in study after study that's done in a community setting. Efficacy trials, we were getting like 20% dropout. And so it was also like, oh, there's not a lot of dropout. And this is not personal to PCIT. Dropout is very, very high in community settings for any intervention. So engagement's a real issue. And engagement is impacting the client. Like I showed with that graph, they're not going to have those good outcomes that last for a lot of different years. It is impacting the therapist. It's a big implementation issue because, for example, with PCIT, you have to really learn how to do the model and to get certified in it, you need to be able to graduate 2 cases. If your cases keep dropping out again and again, you're not able to get certification. You know, they're finding that it takes sometimes up to 3 years for therapists to get certified in this model. And so that's a lot of time. That's hard on the therapist. It might affect some of those implementation outcomes, right? Like your attitudes and your costs. It's really impacting agencies. They're having a hard time. Any agency, they invest a lot in any evidence-based practice, and then all of a sudden they're not able to recruit the right clients, or they're not able to keep them in treatment. And so it's expensive, right? And then communities, and again, the public health just in general. If we don't have good engagement in mental health services, we're not having the bang for the buck that we want. and the ugly. So we have the good, that they exist, the bad, and then the ugly is that there are also mental health disparities. And so mental health disparities for the reach of evidence-based practices, I really like to conceptualize that these are driven by supply and demand. So there's supply issues, there's an inadequate workforce to deliver culturally and linguistically competent services. That's a huge issue within Miami, I'm sure, and I can just here to tell you it's a bigger issue outside of Miami because there's a lot of providers, for example, who can provide care in Spanish or Creole here in Miami. There's fewer in a lot of other settings, but there's still large immigrant populations. And then there can sometimes not be enough demand for these services too. And this is something that we don't think of as much, but because of stigma, because of lack of knowledge, both not knowing that the services exist or not understanding what different symptoms might mean. You know, if you have a child with ASD, for example, like not maybe having the knowledge of understanding these are typical developmental things and I might need to go to talk to my doctor about this. You might not demand those services. And there's logistical barriers. It's harder when you're working long hours and you're not able to access care. So all of these can help exacerbate mental health disparities. And mental health disparities we know are significant for individual racial and ethnic minorities, but just in general, access is really bad to mental health care. So only 31% of white children with mental health problems receive mental health services, which is not great at all. That's less than a third. But only 13% of children from diverse racial and ethnic backgrounds with mental health problems receive mental health services. And this is a growing population in the United States. So this is really something that research needs to be focusing on, is how to close these disparities. And implementation science can be seen as a quick fix to mental health disparities, but I would say that it has not been researched well enough. There is a possibility that we're going to use implementation science and implementing evidence-based practice and we'll be able to decrease disparities because it will increase reach and it will improve quality of care in community settings across for all, right? And really reach underserved. But I'm going to argue that we really need to be mindful and thinking about this whole process because a fear could be that implementing evidence-based practices could exacerbate mental health disparities. It could increase them if we are implementing really good evidence-based practices in some settings where it's improving care for some but not others. Do we have good culturally relevant materials when we go out to do this dissemination implementation? Do we have the bilingual professionals to be able to deliver the care? And so there's this question, and it's been under-investigated is what I would say. So now we're at the part of the talk where I want to go over 2 examples of ways that you could really be centering your conversation around implementation science and mental health disparities and thinking about potential services. And one of the first ways to think about this is workforce solutions to be addressing disparities. So I'm going to talk about lay health worker involvement in interventions. And I had some very special guests who walked in here, and so I just want to shout out hi to you guys. You're going to see some photos you recognize. So lay health workers are a population of the workforce that has been leveraged more in international settings for global health and global mental health. First of all, that's where the majority of the research has come from. And also the majority of the research has come from physical health domains. Okay, so task shifting for HIV, for example, on what lay providers could be doing in Africa has been a huge area of focus. But this is extending now to all things, including mental health. And so lay health workers, let's think about this model. If we're saying that there's supply issues and there's demand issues, and that can lead to disparities. Lay health workers are bilingual providers. They're often from the same cultural group, and they have specialized roles that can help increase the supply, either because there's been complete task shifting where they are the ones providing the care, or they're taking over specific parts of the job that a full-blown trained professional might not need to do. So again, bringing it back to the health side of things, a doctor might not need to be the person administering a vaccine. You could train a lay provider to give a vaccine and to deal with sort of the most basic work, and the doctor would be saved for the more critical care incidents, right? But then the doctor is more available if she is not spending all of her time giving shots. That makes sense because she has more time available. And then as far as demand, this could be a workforce really working on conducting outreach and very in tune with the community to address those barriers to care. And coming from the community that they serve, the potential to decrease the stigma related to that help seeking, hopefully leading to increased mental health parity. So lay health worker is not a term that we've used even in the projects here in Miami. What we're working with here is the natural helper population with Connect Familias. In Santa Barbara County, where I live now, there's a large promotora network, community health workers, a term used a lot, and parent support partner is a term used a lot, especially within mental health settings. And so I know that these are all very distinct workforces, and some people I think actually feel like these are not the same workforce at all. That's why I did a Venn diagram. There are things that make each of these types of workers unique, but in that middle there, the thing that makes them all similar is that these are people with lived experience, they're community members, and they are similarly across the literature often seen as being engagement specialists. They know how to better engage the community. So I'll be talking about lay health workers, and I'm talking about kind of individuals who have these roles. So one example of lay health workers as case care extenders started here in Miami, as Jason alluded to, and this is some work I did when I was on my internship here, when Connect Familias approached Jason and said, we would like to partner with you at University of Miami to improve the parenting services for our family in Little Havana. And we worked together in a partnership doing focus groups, really trying to understand the needs of the Little Havana community, but also the natural helpers themselves of what they wanted, and developed a natural helper plus PCIT care extension model, right? So we did a long bit of training to help our community health workers, our natural helpers, learn how to do outreach, care coordination, emotional and logistic support of parents. They were all pretty experts at that stuff. We really worked on how they could help with the home practice and who would be good referrals for PCIT. And they would partner with a professional provider to do assessment and PCIT treatment and consultation to the natural helper. So this is really a combined approach. And the idea here is not a full task shifting. We're not having the natural helpers deliver PCIT, but we're having them help increase that demand of service and also making it so that the PCIT providers themselves are mostly just doing PCIT with the families. They know that the extra support is coming from others. What just happened? Okay. So what did we find from just our initial training of the natural helpers? Their knowledge of PCIT went up. Their attitudes towards positive discipline techniques used in PCIT went up. They greatly improved their own ability to do the child-led skills and the effective discipline skills. And we thought this was really important because these are our role models in the community, and this is the way that you're able to practice with families, is knowing how to do it, right? And so we had a very successful training, and this, I just had to put it in here. This is my very last day of internship, approximately an hour before I hit the road to go to Los Angeles on the day that they all graduated with their excellent skills. And I can just say that since then, the project has continued, and what we have seen is actually lessons have been learned, right? And I know we have a number of people here who have been part of this project. One of the lessons that was learned was our natural helpers are so effective at increasing demand for PCIT that it widely outstripped our ability to provide the amount of services that we needed to. And so that has led to amazing, that's demand going up, it has increased supplies, right? PCIT is an expanding empire throughout Little Havana and Overtown and Homestead, because we know that our natural helpers will get people in the door. And I have all sorts of feelings about all the amazing things happening here in Miami, but I always think about how do we bring this type of success to other places too. And so right now, I'm very interested in this implementation question with lay health workers particularly, and I really switched to using that more general term because I'm trying to understand how this type of workforce model could be used within more typical Medicaid-funded. Unfortunately, the Children's Trust is not everywhere. Medicaid-funded places where you are having PCIT implemented and all of those engagement strategy problems are there, how can we better leverage the lay providers who are also involved so that they are supporting evidence-based care opposed to services as usual that might not be as effective. So again, looking at how they could impact recruitment, attendance, and skill acquisition, and if that could impact implementation outcomes. So I'm not going to present any results from this part because it's ongoing, but I did extend the work that was done here in Miami to propose a grant to the NIMH, and they thought that it was a good idea. So that's exciting to think that this could go forward. But first, to really understand what the local context in Southern California, Los Angeles County, and Santa Barbara counties are. Who are these providers and how are they integrated into care? We know that there is been a big push, especially in Los Angeles County, and I'm going to get into it, to bring evidence-based practice into care. And we know that one of the big challenges that came up is that evidence-based practices, not just PCIT, almost all of them, require parents to come to services. And it was a huge shift. And families, clinicians were like, this is making it so we can't bill for services because you're making us do things that the parents come and we're only used to working with the kids. And so they started hiring promotores and parent partners, and there's been kind of this mad dash to figure out how to engage parents, but we don't really know how it's happening. So I'm trying to figure out the lay of the land there with interviews and surveys with agency leaders and lay health workers, and so that can lead to a community partner refinement of, I'm calling it LEAP, the lay health worker enhancing engagement for parents model, and making it so it can actually be implemented and billed for and all of those things that you would want, so it can be kind of a sustained project in other settings. And then eventually, this is leading to a small pilot to understand how these enhanced PCIT, does it actually improve parent engagement when you compare it to just PCIT as usual? And does it change service and implementation outcomes? So does it change things like the rate in which a PCIT therapist can get certified, or the number of families that continue through treatment? So that's what we're looking at now. I'll come back in like 5 years and give my next grand rounds about what we found. But it's time to move to the next example of how implementation science might be looking at mental health disparities. And I really want to focus in on solutions that are focused on the practices themselves, the evidence-based practices themselves, and how they can be adapted to increase acceptability. So I've said it before, I'll say it again, these practices were developed in the ivory tower. And what we know is that families in our effectiveness trials, or just in community settings in general, are much more diverse. They have much higher rates of comorbidity of multiple different types of mental health and other substance use and developmental disorders, and they're more likely to be impacted by community violence and poverty. So different types of clients. And there has been a very large literature, well summarized by Dr. St. George, on what processes can be done using a research community partnership to adapt these practices to better fit different groups. And that has been a whole process of where you are systematically coming up with adaptations of a practice and then testing, does it work? And in the most ideal types of trials, does it work? How does it work compared to the unadapted model? And this is a very important line of research and has certainly done a lot for us to understand cultural adaptations that need to be made to practices. It's very hard, though, because what then happens to disseminate those practices out? It's like then you have another evidence-based practice that you have to disseminate to implement in a community setting. Do those materials ever get out to the community? And second of all, are you going to do a different adaptation for every group? How does that work? And so in implementation science, there has become a little bit of a push to start looking at the types of adaptations or tailoring or modifications that therapists themselves are making to make the EBPs work for their clients. And this is a forever going tension between fidelity versus drift. You know, are we actually delivering it with fidelity if we adapt? So this is a model that has a framework that was developed by Wilty Sturman and then adapted by my colleagues at UCLA, where you're thinking of adaptations are a type of modification. Like I said, they're planned and they're systematic. And some of them are fidelity inconsistent, and those would be considered things like removing the core components of treatment, the things that we would imagine are the most likely, the bang for your buck. I said that a couple times, but like the things that you have to do to make that an effective treatment. And if you're taking out core components or you're drifting, you're getting a little loose in the structure, that might be an idea that it's being fidelity inconsistent. I messed up on this. And that should be reducing reordering. And then fidelity consistent things, though, these are more your tailoring, making the wording work, maybe supplementing with things. You're augmenting the practice in a way that could promote engagement for the client and for the therapist with their implementation, too, that they're feeling more invested in the care. So this is something that I studied extensively on my postdoc, which was at UCLA on the 4 Keeps project, which stands for Knowledge Exchange on Evidence-Based Practice Sustainment. The 4 Keeps project was an observational study of a large transformation that happened in LA County related to implementing evidence-based practices. So LA County is right here. So here we are. I hit that road after that photo with the natural helpers and drove here and ended up here in this county in red, which is shaded in red so you can see the size of the county. And then all of those other states that are shaded in blue have smaller populations than LA County. So when I say that we are talking about a large change, just because it happened at the county level, it was massive. And basically, other things to know about LA County, it is very racially and ethnically diverse. The majority of people who receive care from Los Angeles County Department of Mental Health are Latino. And what happened there is they had, in 2005, passed what is colloquially called the millionaire's tax, where they taxed at 1% the millionaires in California, and we have a lot of them because that's where Hollywood is and that's where Silicon Valley is. We have a lot of millionaires, and we generated a ton of funds, and it was going to go to innovation in prevention and early identification of mental health. In about 2008, we had a state budget crisis, And all of a sudden, a lot of carefully set plans on how you were going to slowly roll up all of these evidence-based practices in LA County. That's what LA County decided they were going to do with their money. It became the only funding available for mental health was this physical amount of dollars that it had to be billed towards evidence-based practice. It became a fiscal mandate. All of the contracts were modified, and they trained thousands of providers in like a 6-month time. And you guys can imagine it was a mess. And the 6 practices that they had, there was 52 practices that you could bill for, but there were 6 that got county support. The county put on the training and the consultation and paid for all of that. And they were triple P, cognitive behavioral intervention for trauma in schools, seeking safety, which is a practice that is dual diagnosis, substance abuse, and trauma for adolescents, managing adapting practices, which is a modular treatment for just more like depression, anxiety, disruptive behaviors, TFCBT, and child-parent psychotherapy. So you will see PCITs not on there. It is a practice you can bill for. It was kind of a whole separate thing going on with PCIT at that time in LA County. But part of the reason that they did only 6 and support it was even the developers, you're calling up and you're like, we need you to train 3,000 therapists and provide consultation. And like, not everybody was ready with infrastructure to be able to support those efforts. So that happened, and it became an amazing natural laboratory to study implementation, right? So the 4 Keeps project is looking at what happened in the sustainment phase, 6 to 9 years out from when this original PEI transformation occurred. And we have looked at so many different things with attitudes and trajectories of how much is actually happening. Fidelity, there's a lot of questions that Joyce will get to be part of answering. But what I'm going to talk about is what was happening with adaptations that therapists were making to make these practices work for their diverse clientele. So we did a quantitative survey of, I thought I wasn't in there, 557 therapists, or actually 572, I don't know where that number came from, on 6 adaptation items that were taken from the Wiltsey-Sturman framework. And then qualitative interviews to really understand how these adaptations were being made and why and for whom, right? Like, what reasons do you have for that? So the way the survey worked is it would have an item like, I modify how I present or discuss components of this practice, and then they would answer it for every practice that they had delivered within the past 2 months. So in this case, the therapist would have filled out that they had done 3 practices, but if they'd only done 1, it would only ask them for that 1. And then we did interviews with 60 therapists across agencies, really representing different types of practices being delivered and geographic locations. LA County actually has very rural parts too, urban. We just wanted to get it all. So on the survey, for the most part, people were reporting that they were doing more of these fidelity, consistent, or augmenting adaptations. So that's encouraging. And less fidelity and consistent adaptations. And things that were predicting that were attitudes towards EBPs. So actually people who had worse attitudes were doing both types of adaptations more. And we found that our Latino therapists, which was about 50% of our sample, were reporting that they were doing fidelity consistent adaptations, but that did not predict but be fidelity and consistent. So that seemed promising. So we found some interesting things with our quantitative findings, but we really didn't have a good sense on what's driving these adaptations. And so we wanted to delve into that more. And so we asked therapists about the adaptations they made in their interviews. And we went back and we coded them using this augmenting, reducing, reordering codes as the types that they were doing. We also looked to see if there were other types of adaptations and didn't find a lot of other ones. I'll just leave at that for right now. And then what contexts were there? So there were client background characteristics like their culture, their developmental level, or their literacy level that were coming up as themes as to these are reasons why I need to adapt. And then there were clinical issues like the clinical symptoms of the youth themselves or the family caregiver functioning or emergent life events. So things that were crises of the week, things that come up in treatment that you haven't planned for. That's not what you're focusing, but all of a sudden, mom and dad are getting divorced, right? And just to give you a quantitative view on what, this changed, color coding, how it changes in PowerPointing. We looked at how often these types of codes co-occurred, okay? And so this coding is wrong, but modified presentation is the thing that's been done the most, and it's supposed to be the blue. And so people were talking about modified presentation a lot across all different things. And then reducing and omitting, that's the thing that we would be the most concerned about. That is red. And so we actually found, okay, so actually, interestingly enough, people are omitting for different reasons. Let's think about what this means for the fidelity of the model. So we went to our illustrative quotes, which I have a few of here. Like I said, culture, the biggest thing people were talking about is need to modify presentation. They have a lot of examples of not only translating a practice, because that's just translation, but really I have to change the lingo so the parents can understand, right? Like you have to make the examples actually ones that make sense. We're not going to say antecedent, maybe, if that's in a practice. We would say the thing that comes before. There was also a lot about the developmental level of the youth and having to integrate different strategies. Like I do a lot of therapeutic games. I bring in other coloring activities, like more feelings, but big faces and things like that, right? So again, you can see how this is just tailoring the presentation. You're making it appropriate to the age and the culture of the person that you're seeing. And then when you're looking at reducing and reordering, emergent life events came up as a big need for reordering content. People would say, if a crisis comes up that week, then I just fast forward to the topic that talks about that. Which could maybe not be as fidelity inconsistent as we're afraid of, but also potentially is still derailing treatment a little bit. So need to look into more. Youth clinical symptoms and reducing was interesting. One of the biggest things people talked about is if a child doesn't have a symptom, they won't do the practice. So in this quote, they're talking about, and I do believe it was for TFCBT, half of my clients have cognitive disorders, but some of them don't. So if that's probably the piece that I don't use as often as other pieces. So they're saying if a client's not having cognitive distortions, I don't teach them about cognitive distortions. And again, you go back and you say, maybe we really need to be understanding why people are reducing. Sometimes it actually might make sense. Maybe it's not always a bad thing. Not to say that it's always a good thing, but we need to understand better and prepare therapists to know when these are appropriate adaptations. So final thoughts before we move to questions. I just want to say that when you are thinking about bringing a practice, and whatever that practice might be, is it a screening procedure? Is it a different type of therapy into a community setting, especially to reach the most vulnerable and underserved populations, to really identify and address both supply and demand drivers of disparities, to really understand, do you have the workforce there? Are people going to feel comfortable with this intervention? And what can you be doing to make sure that both of those things are in place so that you are not implementing a practice that nobody wants yet because they don't know about it or they don't feel comfortable with it. Plan for adaptation. It's inevitable. And if we pretended like these practices were being delivered exactly as they were packaged, we're doing everybody a disservice. Instead, what we need to be doing is planning for it, helping our providers understand when it's appropriate and what it might look like for, and measuring it. Take note of what you're doing to make these practices work, or what you're doing and maybe it's making it so the practices don't work, so that you could adjust from there. And really study how the implementation occurs, because it's not enough to know. If you walk away and you're like, oh, wow, it's time for our final report to our funding agency and we're not finding those effects that we thought, and it turns out this practice that I thought was really great was bad, we're going to ditch it. Maybe it's not the practice, maybe it's how it was implemented. And so if you really understand that process and you understand how you can change that, potentially you want to just strengthen the implementation up opposed to changing practice. And on that note, I'd like to take questions and acknowledge everybody who has helped get me here. So thank you.
Questions for Dr. Barnett?
Yes.
Whenever you introduce something new to an underserved population, in my experience, that there's always challenges, starting with logistics, cost, some territorialism, as in, what are you doing here? And culture can play a role in that as well. You know, in your experience for this type of outreach for evidence-based practice, what's the greatest challenge or group of challenges that this would encounter?
Oh, that's a big question. I think that it's really great that you framed that question around what would be considered the exploration phase, which is right when you're approaching a community and talking about bringing in evidence-based practice. Because I think the challenges that you're seeing then are potentially very different than the challenges that you're seeing down the line. So I'm gonna pause on that question, for example, and I'm gonna talk about really quickly another finding that we found from the sustainment phase. So this has been now happening for like 6 years at LA County. We looked at what characteristics of evidence-based practices therapists found to be more appealing, both in quantitative and qualitative. And we had the assumption, because we had heard it again and again and again in the literature, is that when they measure therapist attitudes about evidence-based practices, one of the biggest findings is that these are too structured. They're too directive. You have to do it. It's a cookbook, right? And we don't like that. It's not open and free enough. But what we found was when we compared one evidence-based practice to another evidence-based practice to another, so not just usual care, not just doing what you want, one of the biggest themes that came out qualitatively, and something we found quantitatively, is that therapists had a preference for structure. They said, I really like the structure. I just like knowing what I'm doing every session. I like the therapies where they just tell me, like, do this and then do this and then do this. And so it can be different what happens after it's been implemented for a while. So that I say that anecdote to bring me back to your question on, like, what are big challenges? I think that big challenges often are attitudes at the beginning and perceptions. I think that there is often a good reason why people are feeling that this isn't a good fit or protective, and it can be things like the cost, and having to change and having to learn new things can often feel very unsettling, and can feel like the people bringing in the new thing are not really understanding the needs of the community. So I would say that one of the most important steps that you need to be doing at the beginning is having your efforts be driven by some need on the community, and really meeting people with what it is that they want for their clients and for themselves, and how can you come together and build a partnership so you're meeting those common needs. So there are a number of implementation strategies around partnerships. Champions is a really important thing, having at least somebody in the agency who's really going to champion this effort and cares about it, even if it is hard, that can help with that. But those are the types of strategies you might have to implement at the beginning, at the exploration phase, when there might be more of that resistance. And actually, I think it's underplayed. I do think cost is probably one of the biggest barriers, though. And that is one that I don't have a solution for yet. Other questions? Yeah, Drew.
This is such a great presentation, so thank you for taking the time to come to us. As you were talking about sort of the implementation science side of things and how that's funded through NIMH, I was thinking about another grand rounds we had a few weeks ago with the director from NIMH, who came and talked a lot about the RDoC initiative. Mm-hmm. And I think that, and this is sort of like, I think it's simplifying a lot of maybe much more complex issues, but I think one of the main ideas behind RDoC is, well, we're not meeting the reason why mental health difficulties aren't being reduced to the extent we want to in this country is because we're misidentifying the diagnostic categories. So there's like a bottom-up basic science approach, and then there's an implementation science approach that you're talking about here today.
Oh, implementation. So
I guess my question boils down to like, to what extent, and it's a much larger field-wide question, but like, to what extent do you feel like we do have the right treatments and they're not getting out versus, you know what, we don't have the diagnostic categories correct yet, and therefore that's driving some of the ineffectiveness of our mental health interventions?
What a tricky question to have me being video recorded. I would say that probably both approaches still need to be taken. I don't know that we 100% have the exact right interventions. We certainly know that there is a large population of individuals that are not treatment responders for a whole range of psychosocial interventions and medication, which I do think is a huge driver behind RDoC, is coming up with different medications, not just different therapies. I think that another mission coming out of NIMH, as they've looked at their portfolio and how it's changed since RDoC, is thinking about short-term and long-term investments for public health, and the short-term interventions really need to be around implementation science, because even if you change things, it's going to take so long to develop. First, identify these mechanisms they want to identify with RDoC, then come up with what the new intervention is going to be, and then getting them out there. It again takes us back down that 17-year odyssey, and I would say the problem is too pressing right now to wait. And we have to really be thinking about what can reach our most vulnerable populations and be acceptable. So I think we should be ever improving the state of the science, and at the same time working to make sure that we are getting the best care out there. And then that brings us to a whole different question around de-implementation, which is a huge part of implementation science that I didn't get into yet, which is when, if you find out an intervention isn't effective, how do you actually get people to stop doing it? And I've heard really fascinating talks on this and things that they've put into place to get, doctors to stop prescribing certain medical procedures and putting things in where you have to put a reason for why you would override the system that doesn't allow you to do a certain procedure that would be potentially harmful. And the biggest answer I think that they found was semicolon, 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 because people just were hitting it 3 times. So even our implementation strategies to get de-implementation to happen can be not foolproof, but that's a whole different thing. So I would say, eventually we might say, oh, wow, we've been implementing this whole process and it's not as effective as we thought. We need to de-implement it. That's probably going to require some strategies too. But for right now, I would say people can keep doing RDoC, but that doesn't stop the fact that we have a lot of knowledge, but also that it's not necessarily changing. And I say for everything, everybody should always be thinking long picture, how are we going to get this to the hardest to reach place, and how can we make that work the best? And our mental health interventions have not been well designed for that yet. And the more we start designing with the community in mind instead of the most ideal situation in mind, I think the better that we can be meeting those needs too. Great.
I have time for one last question. All right.
All right, properly. Thank you everyone for having me.